needles, air pockets, and x-rays on this episode of Viral Unpacking Podcast. Let's go get it. Hey guys, thanks for joining me today on the Viral Unpacking Podcast. I'm Charlie Swearingen. Today we're going to review a content creator that goes by the handle FlightMedicBerry. Awesome flight paramedic. It's got a lot of really good practice type content. If you know me at all, you know that I'm not just the educator that wants you to learn stuff for the test and nor just do it in the field, but we have to practice that, the bridge between those two. So FlightMedicBerry has several different parts or several different options on his channel, specifically here on TikTok, and that really gets into practicing and putting you in situations where you need to make a decision. So he gives you a great case vignette and you figure out what you need to do. We bang it out in the comments, and it's very, very cool the way he does it. It's very colorful. It's pretty entertaining. And if you're not following him, give that dude a follow. He's an advocate of mental health in our field, and I don't think there's enough people that are doing that. So that's pretty badass. So let's get into it today. Pretty simple topic, but this will ring in for all the students out there trying to watch and learn a little bit. So not all of our talks will be very simple. Some will be more complex, but today it'll be a little bit more basic. But again, let's see how he does, and we'll commentate a little bit as we go. So this is the title here, of course, is Let's Talk Trauma, and with FlightMedicBerry, he's got a pretty decent demonstration at the end, in which case after that we'll jump into those comments. So let's get to it. Let's see what he's got.
And we got a cool one today, so stick with me because what's going on, everybody? It is FlightMedicBerry back at it again, hang out with you guys, my fellow flight crew members out there on TikTok, and we got a cool one today, so stick with me because we got a good demonstration at the end of the video. So today's topic is going to be talking about a pneumothorax, or also known as a collapsed lung. So a quick rundown of some things that can cause a collapsed lung are really seen in the traumatic settings, such as penetrating trauma to the chest, like a gunshot wound, a stabbing, and even a blunt injury, such as a baseball bat to the chest.
So he starts out pretty good with, just keeping it real simple. Like, the pneumothorax, big word, meaning, air is in the chest. And so then he starts getting into some of these reasons that air would be in the chest. And especially for students and folks who may be doing it maybe a year or so as a review, there's a couple different ways that could manifest. And it's really like the condition of the chest. Is it open or closed? So you could have a spontaneous pneumothorax. The one idea that we always think about is like if you overbag and somebody's got a weakened part of their lung, kind of like a bleb or essentially just a weakened wall, and we overbag, we overventilate, and we pop the lung. Well, now there's a hole in the lung lining of the lung, and air gets between the chest wall and the lung and collects with each breath, collects more and more and more and more, and this air pocket is now there. It's not supposed to be there. If it's penetrating, then all of a sudden the negative pressure in the chest is no longer there, or at least under the lungs up to the diaphragm. And then so when their diaphragm drops down, air rushes in from the outside. It doesn't maintain that negative pressure and allow the lungs to inflate. So the lungs just kind of stay shrunk, or if it's just one side, then that one lung will stay shrunk and not expand. So those gunshot wounds and stabbings, those cause open pneumothorax, thoraces, where what we need to do there is that's why we put an occlusive dressing on it, right? We tape it on three sides, mainly so as the pressure builds up, the air can eventually burp out as the pressure of the chest builds up the tension, and it can burp out, right? But it can also happen with a closed chest, and that's just because the inside of the lung has been busted. So thinking of those two juxtaposed next to one another is if you have air either gets in because the chest wall is impacted, which is that's your penetrating, or that your lung tissue has been ruptured or impacted, and therefore air comes in from the inside and goes out, whereas the open pneumothorax, air comes from the outside in. Now, if penetrating, you can also damage the lining of the lung. So with penetrating trauma, you can also have a injury to not only the chest wall but also the lung wall itself. So you can have both. But in the end, when you put that, the whole point of putting a occlusive dressing taped on three sides, or really just an occlusive dressing with a vent somehow, You're allowing that air. You're sealing it to where when the diaphragm drops down and negative pressure is created in that lung, then that cavity rather, then you seduce the lung to come all the way back to the outside and fill with air. And so over time, if there's a little bit of air that's still leaving the lung, then and that's why the point I brought up of sometimes you can have both the chest wall and the lung wall injured. In that case, you seal the wall, and then so as air comes in and begins to expand the lung again, maybe a little bit of air comes out of the hole in the lung, and then that begins to build up over time. And as that pressure builds up to a point where it's greater than the flap of the occlusive dressing, it'll basically burp or fart essentially out. I can't believe I said fart. I can't. I say stuff like that. Anyway. Okay, so that's kind of the gist of that, and I like sometimes like really talking about like the difference between the closed and the open pneumothoraces, and just like a little bit better concept. So, but he's doing a great job here. Let's keep going.
So since you guys are my fellow crew members, I'm going to need your help on this one. I have an x-ray behind me that was given to me by the facility, and what do you see? What doesn't look quite right? Now, if you would have said there's something not right on the right side of the patient, you'd be correct. Now remember, x-rays are kind of a flipped image, so that is right and that is left. So when we're looking at chest x-rays, we're looking for a lot of things, but one thing is symmetry. What on that side is not on that side and should be.
So one of the things he's looking at here, of course, now we can't see the whole X-ray, and so granted, and people jump in the comments like, "Oh, it's not a good X-ray because we get it. This this is a little bit. We still can derive a little bit of information from this." One thing that you see that I always try to explain to folks is like a little bit of marbling, like on a steak. You want just enough marbling that look where you have like little veins of fat and everything. So these aren't fat. This is really just airways. But where you can see it's a little hazy, but it's not too hazy, and you see these little strings, like again that I was calling fat earlier. You can see they go all the way out to this outside. Over on this side, this is hazy, but there's no, especially down here, it's not even really hazy. It's dark, and so we don't have this over here, right? So this is lung with a little bit of the heart right here behind him, but this is lung tissue. And there's lung tissue there. You can see through it, mostly air. That's why it's hazy and not if it's a lot of fluid-filled cells, then that gets more and more white. If it's nothing there, if it's just air, then it's more black like this. So this is the border of that right lung, and all this is air caught in there that we need to do something about. And so this is what he's pointing out here, and I'll let him kind of finish.
Clearly, there's a black blob that isn't on that side. The
right
blob you see is air, and that air is reflecting of the air that is pushing on that lung and causing it to collapse, or also known as atelectasis. So now that y'all were able to identify there's something wrong on the right side, it's most likely air causing the lungs to collapse, we need to decide if we're going to intervene or not.
So the interesting thing here is, and those of you that are in the field as far as flight or critical care, you get somewhere sometimes, and these we don't have to have an X-ray to identify this. This is a clinical finding. When you have this, and especially when there's so much space here, meaning it's pushing all the way to that patient's left side, what's happening there, of course, is that buildup and that pressure will begin to compress the heart and the other tissues in the thorax, and push and reduce cardiac output, reduce preload, and so we'll have a drop in blood pressure, and therefore also with that we'll have a drop in SAT because we're not delivering blood anymore. So when you have a concurrent drop in blood pressure and saturations, they both drop together, and you have a mechanism that you don't have to go get an X-ray at that point, right? We can go ahead and do what he's gonna tell us about here in a second. Now, the more difficult times is if somebody's short of breath, but the blood pressure hasn't dropped. But like you're just, especially if you're going to put them in an aircraft, you're going to go up to altitude, and there's mechanism. You want to look at a most recent chest X-ray. If they've been sitting there for like an hour and they had chest X-rays right when they came in, but over time they've had a little bit of shortness of breath, increasing, and a little bit more pain, then like there's nothing wrong with having, hey, can we reshoot that X-ray and see if something's developing? And in the end, like if you have a 15 or greater % pneumo, right, and that's an eyeball, and typically it's read by the radiologist, but if you look at it, if it's 15% of this whole space, which is, it's not much, that can develop into something major, especially as you go up in altitude. He's about to talk about a similar thing with that here in a second. So I don't get too deep and steal his thunder. But the idea here is building into not just, for students or newbies in the field, but for, we all know that we've shown up and they're short of breath and they've been there a while. Like, nothing wrong with asking to reshoot an x-ray. That gets into the politics of the whole thing, and I get that part. But if you can get an x-ray and you can see like, oh, we're about 20 or 30% pneumo, let's go ahead and either needle or more likely we put a chest tube in if that's within your wheelhouse. So anyway, that's how we can use that. And the same thing where typically the tension pneumo is pretty clinical. If your blood pressure and your sats drop and you have that mechanism, you don't have breath sounds on that particular, this x-ray on their right side, then you have all the rights and privilege. Or typically, you have to follow your protocol and your medical control, but most of the time you have the indication there to do the procedure, whether it's needle decompression or chest tube. But he's going to talk about needle decompression here. Let's let him finish.
So as a flight paramedic, there's a number of things that are going through my mind right now, but one is I'd like to interrupt this patient's condition while I'm on the ground, because altitude will actually have a negative effect on this patient's outcome and actually make it worse. So a down and dirty reason why that is because of Boyle's law. As I go up in altitude, that big blob of black air will actually get worse because there's less pressure being exerted on it, so it's going to try to expand out in that chest, and it's going to cause further collapse of the lung and actually start to affect your heart and your circulation.
I'm always impressed with the amount of stuff that we can actually get into a 3-minute span, and the micro learning, the micro lectures that we get off this particular platform is pretty amazing. And, I think that when somebody could jam a bunch of stuff into 3 minutes, it's awesome, which is why I like to review these and actually go a little bit deeper and talk about them. We talk about them on the front end with the video, and then we'll get into the comments, of course, as well. But the reason for flight physiology, or the reason that the Boyle's law happens and essentially that our patient can deteriorate, is because, like, right now there's a column of gas sitting on you from the furthest stretch out to our outer atmosphere all the way to you, and on top of that is a bunch of gas, and there's weight to it because gases are, even though they float around, they're still pulled by gravity as well. So the more and more that you have between you and the outer atmosphere, the heavier that column of gas. So that heaviness or that weight helps push all the gas around it, helps push it together and keep it kind of made to behave. It can't just run amok. Now, the higher you go, you have less and less and less and less column of gas. Therefore, it's less weight. Therefore, it's less influence for the gases to behave or stay together. And so what happens as you go higher and higher, gases are allowed to expand. They're not being forced together because the weight is smaller on top of them, and so they're allowed to expand. And that's exactly what they do. And if you are right now I'm sitting in Mississippi, I think our altitude's like around 400 or 500, something like that, maybe a little less where I am right now. But so anyway, like, pretty close to sea level. And so when the gases are jammed together, those molecules are really, really close. And I usually kind of put like my fist together. If I take a big breath in, then I get all of the normal amount of oxygen I need, because this is where we were either divinely created or otherwise evolved, whichever your persuasion there. But this is how, like, the gas is so close together, we breathe it all in. They're not so far apart that we can't breathe. But that's what happens when somebody goes up to, like, I just moved from Denver a year and a half ago back to Mississippi, and we do 14ers there. That's like the 14,000 foot peaks, and a lot of people walk they climb the 14ers, and that's a cool badge of honor. When you get up to like past 10,000, 11,000, 12,000 feet, you start getting like those oxygen molecules are so far apart. It's the same exact percent composition. At 14,000 feet, at 50,000 feet, there's still 21% oxygen. But because that column of gas here is a big column, at 14,000 feet, it's a tiny column. So there's less weight, and gases are allowed to, kind of basically get away from one another. So at sea level, gases are close. I can breathe them in. But at altitude, like 14,000 feet, gases are so far apart that I take a breath in and I only get a portion of the number of oxygen molecules into my lungs, therefore going across the alveolar capillary membrane, so on and so forth. So this is where Boyle's law that expansion in the chest, if it's already, the problem is already pressure, and you go up, well, the pressure is going, as the pressure around you gets lower, then that gas is allowed to expand and it pushes on that tissue. And so that is an issue. So this is Boyle's law is exactly what happens. And I just like to give a little bit deeper, because you can only do so much in a 3-minute span. But he does a really good job of breaking it down very simply, getting into the pieces, and he does string together several of these in like little playlists. So and then he puts you to practice it. There's a lot of cases that he runs, and that's a really cool thing. And we will look at several of those here in the future. So let's keep going.
So as promised, here is the demonstration. Here is your patient that we just diagnosed via x-ray of a pneumothorax on the right side. And so we're going to perform a procedure called a needle decompression. So before you veterans get me, this is an 18 gauge. I know this is not the appropriate size needle, but obviously for demonstration purposes. So what I'm going to do is I'm going to clean the air.
Before he gets into the how to do it, like we try to put educational content out there. And yet there are some people who do stuff and you're like, ooh, that's not great. But sometimes we have to see through what they're doing to try to get their point. And so instead of being so critical on folks, so he's trying to head that off at the pass. He's basically saying, look, before you gig me on the fact that I don't have all the right equipment or not do it, I'm trying to show the procedure part and make a couple points, even though I don't have all the right stuff, because he's using simulated piece here. He's probably got half a slab of ribs there, and he's going to go through the process, which is still, it's good information. Let's take what we can from it, and not why we do that to one another on some of these, especially as educators and clinicians. Yeah, I don't get it. And so anyway, hopefully we don't do that. But so we got you, FlightMedicBerry. No judging. Send it.
Area. I'm going to find my site, which is the second or third intercostal space, and I want to make sure that I'm going over top of the rib, because I don't want to do underneath the rib, because that's where a lot of blood vessels are and a lot of nerves. So I go over top of the rib and in.
So those motions he's doing, for those of you who haven't ever done this before, is exactly right. What you try to do is you try to find it, and you try to get like if this is a rib, like you try to palpate it, like, okay, you get your sight, maybe you have your other finger right there next to it. You be careful not to poke yourself, of course. But what you're doing is you'll go down, and the thing that I like to do is tap that rib and feel it and kind of walk it up until I feel it kind of go you feel the edge of the rib kind of disappear. And so he went down, and sometimes you have to angle over, and you want to go, basically you have to tap, and then you insert past over the top and down into the cavity, and then you'll pull the needle out, and I'll let him finish, and then I'll finish.
And so once it's in and you pull out the needle, you should hear a nice rush of air, and that should let you know that you are in the right spot, and now you're relieving the pressure that is on the lung and helping your patient.
And so there's not always a rush of air, although this, like a week ago, I heard that, or maybe it was the last hitch. It wasn't this hitch, it was the last hitch, but we were putting in a chest tube in a patient that had MVC and a bunch of rib fractures you could feel, and a bunch of other. She was banged up pretty good, and the EMS crew had needled him a couple times, and then we flew to meet them, and then we walked in and needled, and my partner needled, and I was like, I was so excited. I was like, yes, I finally heard it, because I've never heard it in the field before, and I've been a medic 20 years, almost a flight medic for 20. I guess a medic for 20 years. Yeah, exactly. I'm 18 as a flight paramedic. But anyway, it's the first time I've heard it, and I've done that a bunch. But then, of course, after that, we dropped some chest tubes. And so we're going to get to some other talking about that at some point in the future. However, once you have that in, the thing that I always tell people is like, great, it could retension, right? Especially if it's banged up from the inside and you have an intact chest wall, then whatever caused that the first time could retension again. So you might have to continuously do it every few minutes. What do you look for? You look for signs of perfusion, because as the tension begins to build, then you're going to start seeing the effects of that increased pressure in the chest pushing against all those tissues, and it drops cardiac output because drops your preload, and therefore your SAT's going to suffer too. Now, here is a little pro tip. If you have them on the ventilator, And let's say you're doing a volume delivery mode, right? When we use the ventilator, either you choose volume or you choose pressure. If you're doing a volume ventilator, then you listen, like basically if you, and I'm going to spare the long lecture of this, if you get the patient set up, and then whatever their PIP is hitting with that volume, let's say you put 500, 400 in, and then you set your alarm, your high pressure alarm, I want it to ring at about 35 or 40 typically. All right, so if I bring that alarm down to but you take a reading, right? So let's say that you put them on 500 and you measure the peak pressure, and the peak pressure is, I don't know, let's say 18. All right, so the pressure is 18. I'm going to add about 5 or 7 to that. So I tell people, like, let's just add 5. So let's go from 17, adding 5, that gets me 22. I'm going to take my high pressure alarm from about 35 or 40, which I normally park it, and I'm going to bring it down closer to 22, 23. And what I'm doing there is, before you see the effects of dropping cardiac output from drop in preload, this is also assuming that they're intubated on the ventilator, what you'll see before the drop in heart rate, before the drop in blood pressure and SpO2, what you'll see before that is a building pressure, because that's the pressure is the mechanism that causes the drop in blood pressure because of drop in cardiac output, because of drop in preload. The pressure is what causes that. So if you have them on the vent and you just get them on the vent, you start watching their pressure, and the pressure kind of, whatever you have them on, and again, this is the volume version. If you're in volume and you just watch that pressure, and let's say it's started at 18, 19, just add 5 or 6 or so to it. And then that's where you put your high pressure alarm. So they're chilling out at 18, 18, 18, 18. As they begin to build tension and that pressure builds and builds, they'll go from 18, 18, 18, 19, 20, 22, bing, and then you get that high pressure alarm. That high pressure alarm now is telling you, I'm retensioning. So what a great way to, that anecdotally, you'll see minutes before the blood pressure and SpO2 drop, you're catching this way earlier. It's a great thing. If you're in a pressure mode like the Hamilton, then you set the pressure, right? Because it's a pressure mode. Even though if you set like the volume targeted modes where, you're still, the Hamilton only delivers by pressure, and it targets volume, but that's, again, a bigger conversation. But you set your pressure, let's say your pressure at 15/5. You got 15 of pressure control, 5 of PEEP. Then what you'll do is you'll watch your VTE, your exhale total volume. And let's say they're outputting about 400. Okay. A few minutes later, and you've needled already, and then maybe it's been like 5-10 minutes, and you look over and you start seeing you get a low VE alarm, a low minute ventilation alarm, and you look over and your VTE, the exhale total volume, is no longer 400. It's like 150 or like, significantly lower by 100 mils or so. They're building a tension. And you can also watch it trend. If it's 400, 400, 400, 385, 385, 360, and it starts to keep, and it gets down to the low 300s from starting point of 400, you're watching tension build. So it's a time to re-needle or put a chest tube in. So very cool things, just kind of adding in with FlightMedicBerry here. Let's jump in these comments. So Taylor Keeley says, or Keel, sorry if I mispronounced that, Taylor. Do patients ever code if you pick up on scene and the medic on scene didn't advise of the collapsed lung from Boyle's Law? So the answer is yes, and it's dangerous. And so, but in this field, we trust but verify, right? So there's various levels of not only clinicians, but there's also various levels of skill in those boxes. Like there's some EMTs that are fantastic. There's some that don't try very hard. And there's the same thing with paramedics, same thing with doctors, same thing with nurses. So the idea, and also these are tough situations where there's a lot going on and maybe we just miss something. So the point here is, yes, that can happen, but you should do a good job. I mean, the majority of flight clinicians out there are not going to miss that they're potentially tension. I mean, if it's a wreck and they're compromised at all, meaning, their mental status, their blood pressure, heart rate, SATs, if any of that's compromised, we're going to do that full assessment. We're going to be looking for these things. And in the end, if their blood pressure is labile, but their SATs are 94, but not better, even though they're getting 100% oxygen, we're probably going to consider, especially if they've already needled once before, we're probably going to needle them, and we're probably going to prep for a chest tube or finger thoracotomy. Finger thoracotomy, once you basically you punch through like you're doing a chest tube, but that's it, and that's, you put a seal on it. You basically institute a penetrating injury, but you're doing it therapeutically, and that's to let any fluid or gas out, and then you slap a seal on it so that when their diaphragm drops down, it pulls the seal towards the hole, so it seals it, and that lung can expand. So, yes, and then of course, if you don't pick up on that and you go up at altitude, then yes, it totally can worsen Boyle's law. Higher you go, the bigger the bigger and more dangerous your pneumothoraces can be. And in adults, we typically don't fly so high that it's like magnanimous, super dangerous, but it can. In pediatrics, the smaller the pediatric, closer toward days old or weeks old, a tiny a pneumothorax on them at going up to 1,500, 2,000, 3,000 feet could mean catastrophe. So that's where we're like, you'll hear us all say, or if you start flying or anything in the flight world, you'll hear us say lowest possible altitude, lowest safest altitude, please. And the pilot's got to do what he's got to do he or she's got to do to be safe. But please don't go extra high if you can avoid it. And so that's kind of those conversations. All right, Samantha, of course this would cause pain. Would you give them some type of medication first? So it depends. If they're unconscious, we send the needle. If they're awake, then you can, like, walking into the ambulance, a lot of times we'll already have our medicines, not pulled up, but like kind of in hand, walk over and go, yeah, let's give it. And we'll quickly give, fentanyl's a great drug to give, ketamine, depending on a lot of things. It's a safe drug, but your drug choice. But the point there is you can get in there and get some pain medicine pretty quickly. But if it comes down to them being sick, sometimes we have to be, sometimes you're forced to be barbaric. The idea is that every single time you try to medicate, if possible, if they're awake, if they're unconscious, then I'm more, let's get the job done really quickly, and then we can start getting them pain medicine and sedatives. But I'm sure that's a little bit of conjecture, but let's see. Not wanting to load up there. I bet he responded. All right, so thanks for stopping by the channel. Feel free to ask questions, drop a comment. So Dave here says, yo, man, I'm in EMT school. Good job, Dave, or J Dave. Plan to get my paramedic, then RN. The overall goal is be a flight medic / nurse or MD. What advice do you have for me? This is good. Let's see what he says. Also, first, always stay humble. But, dude, that is genius. Stay humble. No matter how high you get, remember that there's a lot of people out there that are potentially, likely under your influence, and a little bit of either hope, some good advice, some pearls, all that goes a long way. And being a jerk to people doesn't help any situation, unless somebody is being hurtful to somebody else. So that's the first thing is good. Second, be a sponge lawyer as much as possible. Third, get experience in 911 system as a medic for 3 to 5 years. And I also say 911 system, and nothing wrong with getting rural at the same time. Now you have the acuity and the volume of a 911 system, but now you're also out in rural and you're having to take care of sick people for longer. And the people way out in the county typically don't call until Grim Reaper is knocking on the door, right? And in that case, you have to deal with a sick patient for way longer. That gets you some really good experience too. By the way, check out our Grim Reaper Tears Tumblr. I'll put it in the comments. Okay, so let's see if we can get this to open. There we go. He says, stay tuned for video. Explain it good. He's going to explain more on that. Outstanding. I don't know why this isn't opening. Okay, Cecilia, would you choose to leave that in place or move before arriving at the ED? I think just leaving it in place is fine. And actually, if you have to re-needle, you'll see people, have several. And I usually jokingly say like a full bird kernel, meaning somebody has a bunch, then you had to do it a bunch, and that's like a true advanced street medic move. Is like you drop one, you start seeing it happen again. You drop another, start seeing it happen again. You just keep dropping them, and if you run out of kind of space in the typical target area, then go down a rib, or go up a rib, and just always go over the top of the rib, because like Barry said, the neurovascular bundle is on the underside of the rib, so we just don't go under, we go over. Wish I could combine my L&D. Love this. Yeah, I love the NICU transport teams here. So basically, she's saying I wish I could combine my L&D and SCN with love for helicopters. Love when our NICU transport team walks. We get to fly with our NICU team if it's. So this is an interesting thing. If we go to get a NICU baby, that's redundant. Probably. Yeah. Anyway, when we go get a neonate, we get our isolette from whatever outside base we have, or if we're at the base in the center of Jackson, we grab change out the isolette, and we grab one of the neonate nurses. Now, those are so valuable for us because there are times if a neonate or an infant is discharged and they leave the hospital, let's say that they left the hospital a week out, and as a week old, and it's 2 weeks later, they're technically still in the neonate phase, but they've been discharged. We don't go get a NICU nurse. We get it's us too. It's the medic and the nurse, or the nurse or the medic at our service. We fly all three of those configurations, and we have to do it. So flying with the NICU team, what did Barry say up here? Be a sponge, right here. Be a sponge, learn as much as possible. That's what we do, because in the times that we have to fly with that, and this is kind of out of context, but I'm just reading the comments, guys. I'm just reading the comments. Look, don't hate the man. Don't hate the messenger. All right, do you medicate before you decompress? So again, we've hit that. If you can, sure, but a lot of times this is happening, and we got to do something right now. We gotta knock that out. Or if you can, then absolutely medicate. How do you tell the difference from a pneumothorax and a hemothorax? And would the treatment be the same in the field? So the difference is, textbook, you have a drum sound versus which is like, that's hyperresonant, or hyporesonant, a dull sound, or feel when you percuss. In the end, the whole piece here is, it's tough to see in the field. The whole thing is like, you can't hear breath sounds very well, and they have all these other vital sign issues, or hemodynamics are dropping or whatever. So you really can't tell the field. The typical thing that we would do is, if we don't hear breath sounds on one side, it's a hemo-pneumo, I don't know, whatever it is. And then so we at least do a finger thoracotomy. We'll do a needle decompression if we have to, life-saving, and if that fixes it, then we basically confirmed that it was at least a partial, there was air there at least. If it's not fixed right away, then we'll do a finger thoracotomy and let any blood and or air escape, put a seal on it, and then at some point, put the chest tube in. Sometimes we do that on the way in the aircraft. But the biggest thing is you fix the emergency once you make a hole. The only thing is, if you don't put a seal on it, then the diaphragm can't, when the diaphragm drops down, the lungs can't expand. So that's the thought process. So it's different, but at the same time, it's kind of the same. I mean, pathophysiologically they're different, but the treatment ultimately is the same. If you have air and blood in the chest, finger thoracotomy / chest tube. If you have just air, needle decompression. If you have, let me go back one. If you have hemo-pneumo, then you can put the whether you put the decompression needles here or axillary approach. A lot of people are doing axillary now. It's a good solid move. Then both of those are working, but know that you're not going to need blood out of that decompression. You typically need a finger thoracotomy, which is just a hole in the chest. You do it just like you do a chest tube. You find your spot, you make your incision, and you, with a blunt tip of your Kelly clamps, you puncture through, and then you bludgeon a little bit, and then you put your finger in and do a sweep. Always being careful that you don't wipe your finger over a sharp, rib fracture. So as you enter, it's kind of like, just being very easy, and then slowly figuring out, make sure, can you feel the lung? If you don't feel the lung at all, then it's collapsed completely. And then that's where you want to slap a seal on it, and then allow, when that diaphragm drops down, to re-expand. Now, if their diaphragm is ruptured, which you can't see that, but I mean, like if you don't feel the lung and you put the seal back on and you're still not getting, then we need to do positive pressure ventilation, which is why we intubate a lot of those folks and just put them on the vent, because now we're pushing air in positively. We're not asking the lungs to come all the way to the outside with the diaphragm with negative pressure. So anyway, this was really good. I thought, FlightMedicBerry always does a lot of great stuff, and I hope he keeps doing some good work. Take a look at him, check him out, FlightMedicBerry, TikTok, and he just came up with a new podcast. So I'm sorry, buddy, I don't know. I'll drop that in the comments, or the description. So anyway, thanks for joining us. And again, hopefully this helped. Drop in the comments what you guys want to see at some point in the future, or if you have a great content creator that does really good stuff, then let us, again, drop that in the comments and let us know. Till next time, take care.